Okay.
Gopal,
Okay.
probably
Okay.
doesn't need any introduction, and is one of the most dynamic retinal surgeons in India. Okay, Gopal.
Okay, so mistakes in the diagnosis of sudden loss of vision is what we are looking at. You'll never learn if you don't make a mistake. And let's look at these contents, and we should look at the problems. Many times, incomplete history taking, missing drug history, allergy history, trauma history, etc., can cause a problem. Incomplete examination is another major issue. Misdiagnosing a hypertensive retinopathy basically by not checking blood pressure in an ophthalmic setting is very common. Like we don't do a lot of systemic examination which is complete. That is a major problem. A lot of people do. Incomplete anterior segment evaluation, jumping into conclusion with history and then going on, not checking pupils before dilatation, and diagnosis. Somebody has referred a patient with a particular diagnosis, and you switch off your brain and use the same diagnosis to treat is a major grave problem. Sometimes looking at a CRVO or a vascular block, directly ordering an MRI, getting a battery of investigations, and then finally, coming out with some diagnosis is another issue. Now, with this introduction, let's come to causes of some of the sudden loss of vision, and then let us look at the things. So it could be painful or painless. These are some of the sudden painless causes of vision, like subluxation of lens, diabetic macular edema, vitreous hemorrhage, CSR, CRIO, CRVO, detachment, etc. So let us look at it one by one. In a subluxated lens, you may miss out a family history in which you can have an autosomal dominant or autosomal recessive problem. Missing early mild subluxation may actually delay our diagnosis. Systemic problems sometimes are very, very important, like homocystinemia can have vascular occlusions elsewhere, may come with a stroke. Marfan syndrome also has a lot of heart issues, musculoskeletal issues, which we should not be missing. Sometimes, in the presence of a subluxation of lens, missing alternate pathology can actually be a problem. And IOL power calculations also. Diabetes, I'm just leaving because my MPSR had talked about this. Vitreous hemorrhage, there could be a bleeding diathesis. A systemic history should be asked very clearly. Probably there's a platelet deficiency or even a functional deficiency. There may be a drug history. Sometimes flashes and floaters, a simple history of flashes and floaters may tell us that the vitreous hemorrhage is not a diabetic vitreous hemorrhage, but a retinal tear or a retinal detachment. Sometimes in bleed, underlying cause cannot be seen, which should be picked up in an ultrasound. And sometimes with the presence of a vitreous hemorrhage, we would not know whether there is a subretinal hemorrhage or a preretinal hemorrhage. A submacular hemorrhage requires an urgent intervention, whereas a preretinal hemorrhage can wait for about a month. Sometimes you fail to measure the IOP, there could be high pressures, etc. A central serous retinopathy can sometimes be missed in a patient with mild CSR. And sometimes what can happen is you diagnose it as a CSR, but actually it is a retinal detachment inferiorly. You should always take drug or steroid history, not miss on any, not so commonly prescribed powder or lahium or something like that. Sometimes uveitis may be missed, and it is not actually a CSR, but a sensorineural detachment because of some other thing, either a uveitic sensorineural detachment or a congenital problem that is causing these things. In a central retinal artery occlusion, in early CRIO, there will not be any cherry red spot and you may miss it. And there will be only pallor of the vessels. Pupils have to be looked at. Cause of CRIO needs to be found out, and otherwise there may be a stroke in evolution coming out. Missing systemic problems here may actually prove very costly. And central retinal vein occlusion, in the absence of hemorrhages may be missed. You may have only a macular edema. You may mistake it for a cystoid macular edema. Or an old CRVO, sometimes with decrease of vision, we may not even know that it is an old CRVO because the vessels and the hemorrhages may have become normal. In TRV or vitreous hemorrhage, it may be a little difficult to pick up CRVOs. We should have a differentiation between ischemic versus non-ischemic, and not, NVA and WinVG we should not miss. Retinal detachment, sometimes if it is in the temporal periphery or in the nasal periphery or somewhere like that, it can be missed if you do not do a proper indirect ophthalmoscopy. There could be one or two tears which may be missed. If you find one tear, you label the tear, you are happy, but look always for a second tear. You can miss a choroidal detachment. You should always differentiate the exudative versus rectatogenous, and duration and prognosis are always linked. Choroidal neovascular membrane, you can miss it if it is if there is no hemorrhage. If there is just a small PED, you may miss it. The cause of the CNVM we should find out because it is important for prognosis. Okay, there are a lot of mistakes like DME, RVO, CSR, choroiditis, all can be mistaken. Another thing that we have to find out is healed or active. That is also very important. Sometimes monocular sudden painless loss of vision can occur because of systemic conditions like stroke or something like that. That also needs to be evaluated. Now, what are the painful sudden loss of vision? These are some of the painful sudden loss of vision. In keratitis, cause of keratitis, inflammatory versus infective, these decisions have to be made. Etiological organism, there could be a confusion sometimes in the presence of mixed infections. Ankle closure glaucoma, sometimes you can even miss the ACG. Pupil requires to be evaluated. Sometimes IOP is not measured. Gonioscopy should be done in all patients. And ruling out secondary ankle closure glaucoma like VKH or something like that also needs to be looked at. If you do a cursory examination for a red eye with a torchlight, you can actually miss uveitis, type of uveitis, extent of uveitis, and diagnosis of uveitis needs to be clearly looked at. And healed or active, that decides the treatment that you will give. History is so important in uveitis that you have to pick up a lot of things. Orbital cellulitis, again, infective versus immunologic and cause. You have to pick up, cavernous sinus thrombosis, etc. There could be imaging errors which will happen here. In a case of blunt trauma, you can miss a traumatic optic neuropathy, especially in a systemic setting where the patient is having head injury, etc. You can miss angle recession or miss retinal dialysis. So it's always important in these blunt trauma patients to call the patient maybe after a couple of weeks once once it settles down to look for all this. Optic nerve diseases, missing optic neuritis versus arthritic AIO, the pathology needs to be found out. Demyelination versus ischemia. If it is not typical optic neuritis, we should find out why and how. Papilledema not to be mistaken. So anatomical localization and pathological process is important. On the left, you can see an ocular ischemic syndrome, whereas other side is ocular apex syndrome. The differences in anatomical localization and pathological processes actually gives us a significant. Sometimes these may start separately, like in a mechanical injury, it's easily seen. But after it heals and scars, sometimes you may not be able to actually see. Color-coded diagnostic algorithm is completely prone to error. There are certain people who look at morphological diagnosis. You require a systemic diagnosis rather than morphological. So yellow means this, red means that, this is that, that is. So you need to look at the pathology actually. Now let's look at some binocular causes. Whenever you have binocular sudden painless loss of vision, we should always look for any systemic issues, maybe methanol poisoning, drug involvement, neuroretinitis, occipital seizures, or even pituitary apoplexy, migraine, and psychological. So the eyes don't see what the mind doesn't know, and this is what it is. Okay.